Hi, I'm Nicole Knight. I'm the administrator of Vantage Hospice. I want to welcome you guys today to our very first podcast. So I have been with Vantage there'll be 13 years in October. I've been here since the very beginning. I've had numerous roles in the organization, starting off as the admission nurse and then moving through the director of nursing and clinical services all the way up to the administrator. And today I have with me our medical director, Dr. Joseph Trumbull.
Yes, I'm Dr. Joe Trumbull. I'm been the medical director since the beginning of Vantage Hospice 13 years ago, so the founding hospice medical director. I'm trained in internal medicine, geriatrics, and hospice and palliative care, boarded in all of those. And
we were very lucky to get you because thankfully you were shopping at the time for a new endeavor. So we were very, very lucky that you agreed to come with us all those years ago.
Yeah, I've had some experience in hospice. My family actually was involved in hospice. My mother was one of the early hospice nurses in Houston. And so I admired that and thought someday as a physician, I might actually be able to be a hospice doctor because I thought that was a high bar to reach. And then was able to do that early in my career, get some experience. And then after having some experience, then Nicole and others at Vantage asked me to be the medical director to help found a local hospice.
Yes. So just a little bit of background on how Vantage kind of came about and kind of who we are and how it was formed. So a group of local physicians joined together to fulfill, I guess, for lack of a better word, their desire to provide really awesome hospice care to Houston and surrounding areas. Once the company was kind of established and all the physicians were on board, the real work began, which was really building that clinical piece and that clinical foundation, which is again why we were so privileged to have Dr. Trumbull, who had a lot of experience with a previous hospice that he was, very
involved with that. And the experience that we both have with hospices is not so much a competitive business. It is something which is necessary, needed, valuable for patient care and in the medical community to serve a number of different purposes. But awareness has not always been as good.
Agreed.
People are not aware of what hospice is or what hospice does or what it doesn't do. And so having experience and me having experience from different avenues, we had never worked together specifically.
No, we had not.
But wanted to, if there's going to be a new hospice, we can make it good. We can make it better than we've had in the past and try to make it the best.
I think one of the best things about working with you in the beginning was really, again, I hate to harp on this, but all the knowledge that you brought that I wasn't even thinking about and all the, standard orders and all the things that really made a whole lot of sense and really focused on patient care versus maybe the, penny pinching side, for lack of a better word. I think one of the best things about it is the patient-centered care that we really focused on from the very beginning, and providing the best care that we could. So.
Yeah. And I think you touch on a topic that you have to dispel the myths of hospice. You said the penny pinching. Well, is hospice just out here to make money and cut all the medicines away so they can save money or they're not going to give me the care that I deserve? It's just not true. Hospice wants to provide the care that's necessary, but not do unnecessary things. Medications can accumulate in a patient's profile, which may have had a good purpose or may not have. They may have just accumulated. And with hospice, we rethink everything. So from the medicine standpoint, try to cut it down to what's going to be necessary for comfort or for maintenance of diseases that need chronic care, not necessarily terminal, but if you were to stop, I think a thyroid medication is something. I never stopped thyroid medicine, even though it is not specifically a comfort medicine. But if someone's with us for a number of months and they become hypothyroid, then they may not feel well. Right. And they may have other symptoms that come up. So utilizing the healthcare dollars for our patients is really what we do from that standpoint, from the money standpoint.
Exactly. So symptom management always is a very important thing. But I going back kind of to where we started, I remember the first admission that we did. So that was, we didn't know each other, obviously. We had met one or two other times in the office. And then we had our first admission on December 26th, 2011, the day after Christmas, which was very interesting. So, and I still remember we went out there together like 2 or 3 weeks later to meet the patient. It was a big deal. Our first patient. Since then, we are now, our census usually runs between 260 and 270. So census is the number of patients that we have on service, that we are actually privileged to provide care to. We know that there are a million choices that you have in healthcare, and allowing Vantage to be the choice is a huge honor for us. So we started literally with one patient. We had one patient for quite a while. It was like a month. So getting our foot in the door, even though Dr. Trumbull was very well known, the physicians that were in the group with us were very well known. But again, just trying to get people to trust who we were and what we had to offer, and making sure that we, followed through with what we were saying we were going to do.
Was there a certain number of patients that we had to limit ourselves to initially?
Yes, there
before we got
was.
certified? Because the regulatory aspect of,
So
hospice.
there is a regulatory aspect. So we, in the beginning, were not certified with Medicaid, so we could not take any nursing home patients that were room and board. So that was a challenge. So we did turn down some referrals because of that. But also, we had to service, I think, 7 patients before we could actually get certified with Medicare. So we went through that process, and that was fun. Obviously, a lot of fun. Not. So yeah, it's been quite the journey over the past 13 years almost. We started off with myself and Dr. Trumbull. We had one business office person, and one aide.
Must have had AIDS.
We had one aide. We had one aide.
Most of the care of the.
We had one aide, and we had one social worker and one chaplain.
Okay, which is basically a core team.
Our core team, right? We had our core team of people. So we had no on-call staff. So it was me. I was the admission nurse, which is funny because we had an admission nurse and a case manager. But I was on call, so I did the on-call stuff because I wasn't doing a whole lot of admissions. So I was working on call with our one patient, which we were not very busy back then. But for the first 30 patients, it was difficult trying to get people, not only patients to come on board, but also employees. Because even though we had these grandiose ideas about how wonderful Vantage was going to be, people didn't always believe in our dream and see our vision. So getting people to come on board was a challenge in the beginning. Nurses, social workers, chaplains, as we started to grow, it was hard when you had even when we had 10 patients, it's really kind of getting to the limit of what a nurse can, feasibly manage by herself. And then we were looking for another case manager, right? And nobody wanted to come on board because they were like, you don't have any patients. You don't have any patients. And even though we kept saying, trust us, we're going to have patients. So we finally got a really good core group of people that grew with us for a very long time. And we still have some of them with us today. Mary May, our business office manager, has been with us for 12 years. Most of our chaplains and social workers have been with us for extended periods of time as well. So we have a very stable team and all the same physicians, really.
Yeah, because we knew hospice. We had, starting up a new hospice, because of the regulatory issues, you have to have policies and procedures. Oh, yeah. So we adapted ones that we used in the past. And so we had them, the files and all that. But taking care of the patients was not the most challenging issue. It is forming a team, yes. Forming really what we were consider a family. We still consider a family here of doctors, nurses, aides, social workers, chaplains, and we had to start with one in each of those
yes.
Those roles, and kind of grow that organically, and just find our identity. We had the idea of what it was going to be, but we had to just become that.
Yes, and some of my fondest memories, honestly, were starting. Because it was you and me doing the teams. It was you and I sitting around the table with, social worker and chaplain, and people were so serious. I remember in the beginning, everybody was just so serious. And one of my favorite stories about Dr. Trumbull is you made a joke at one. I don't know if you remember this or not, but you had made a joke at one of the IDTs, and they were all looking at me like, is it okay to laugh? And I was like, it's okay to laugh.
Yeah. And along those lines, I know that my resting face as something it's been serious, and that's okay because hospice, medicine, taking care of people's lives is serious business, but it doesn't have to be serious all the time.
Right.
Sometimes I let it out that I do have a sense of
You do have
humor
a
and,
sense of humor. Yes, sir.
and that, but yeah, we want to make sure that we're professional, and I think that that's the main thing. But yeah, I also want people to be put at ease. And people may not know that I do have a good sense of humor, and I usually am in a good mood.
Yes, he is a very funny man. Yes, yes. But again, I mean, talking about just the team aspect, I mean, that is probably the most important part of not only Vantage, but of hospice in general. So it's really one of the only aspects of healthcare where you have a patient-centered team approach, where it's not just the doctor necessarily calling all the shots and making all the decisions. It's a team and a group of people that are involved with that patient that come in to kind of give their input into what is best for the patient.
Yeah, and our teams, which are regular, we have to have a team of individuals, which we mentioned most of them. Um, we I run a team differently, and I teach the other doctors to run a team. Basically, the doctor does not run the team specifically. We want it to be interdisciplinary, and when physicians are in a room, oftentimes people defer to the physician. And since hospice is so interdisciplinary, we need all of the aspects, especially the aides input, the social workers input, chaplain, and the nurse who's on site to know what's going on. And so I allow other people to speak and to have a greater voice. Because
Yes.
when a physician speaks, people do tend to listen, and that's okay if it's a medical issue. But a lot of what happens in hospice is not specifically medical. It's psychosocial. It's family oriented. A lot of things that will come up in the spiritual nature of that. So that's one way to get a team to come alive is don't be the dominating force, even if, especially if you are one as a physician on a regular basis.
Very interesting aspects. It's true. I remember in the very beginning, again, talking about the hands-on experiences of both you and I. Another one of my fondest memories I still talk about today is the patient that we had in Belleville. I remember the ALS patient. She was like 40 years old, and we had gone to do an extubation because she had, um, decided that she didn't want to be, on life support anymore and
Right.
be kept alive by machines. Um, One of the most, I think, incredible things about you was that you were there the whole time. Um, it was a long ordeal. We had the team was there. So it was me, Dr. Trumbull, our social worker and our chaplain were there. And I think the aide was there too, I think, just to provide support to the family. But just to give you an idea about how hands-on both of us were definitely in the beginning, being able to be there. I mean, we're giving orders and really monitoring and controlling that situation. And I mean, the outcome was it was really spiritual and I mean, it was an amazing experience to be present for that.
And that's what it would be even now at the beginning. But it's just that case required the presence of healthcare professionals,
Mhm.
a physician, if you're going to point where you're extubating somebody who is alert,
Mhm.
and then has decided that they no longer want artificial support. It's a very important decision. You have to make sure that it's done properly. But then when you get down to the execution of the treatment plan, you want to make sure that you're there to support that and support the team, because I think that um, it can be very emotional.
Yes,
It is
absolutely.
spiritual, emotional, and you want to have confidence that you're doing the right thing at the right time.
I think one of the things I also admire about you, sir, is just the ethical and moral compass that you give our organization. One of the things that I always say to people is that we never have to worry about whether we're doing the right thing or not because we have people in place like Dr. Trumbull who, I mean, are very clear about ethical and moral issues and making sure that we are looking at every aspect of those. So I always, if it's the right thing to do, it's something that's going to happen for a patient, which is really phenomenal. Which is another one of the things that I think really makes Vantage different because we are a locally owned, quote unquote, company.
We're not corporate.
We're not corporate.
And not there's anything necessarily wrong with that, but the closer you are to the beginning and to individuals, and that you're more control over the resources and the decision making and the policies.
Right.
And that's what we were able to do, is to develop our policies. Say, well, what is the right thing to do? Well, oftentimes there's different opinions on the exact right thing to do. But when you come together and you work with people that you admire and use your experience, and then and accept feedback and say, well, is this the right thing at this point? And keep it patient centered.
Exactly.
Because there's always a grapple. The ethical issues usually don't have a right answer, and that's when we have ethics conferences and ethics committee. Talk about it. It's like, we're not going to come up with the right answer on this ethical question, because if there were one, there probably wouldn't be an ethical issue.
Exactly.
There's going to be what do we need to do at this point, at this time, for this patient? Hypothetical patients don't exist. And so that's how we're at. So that shows through in our values as a hospital.
Yes. I think, being able to build those values, with more than just one person's input, like you said, I mean, it took a group of people to come together to talk about things. But I mean, once it came down to like fulfilling those and completing those, hiring the right people, making sure that they were on the team, making sure that it was, that the right people were on the right seats on the bus. I think that was probably one of the biggest challenges we had in the beginning, because not everybody, buys into the philosophy of hospice or what we do as an organization. And I think one of the big differences between corporate hospice and a locally owned hospice is the ability to make those decisions without really a lot of the red tape. I mean, it's the decisions for medication coverage, equipment coverage, whether or not we're going to do something really does fall on a core set of people who, are different. I mean, you come together with different values and thoughts and ideas, but kind of tend to, have faith and trust and respect for each other, which I think makes a huge difference. So one of the biggest things I think about Vantage is that the core group of people that are sitting, driving the bus all have the same belief system, which really is patient-centered care and providing the best care that we possibly can for patients. So that, I think that's kind of what differentiates us a lot. I mean, hospice in itself, which is probably not right to say right now, but hospices are kind of limited to what they can do. I mean, the program is the program. You can't really go outside of that program and do a lot of things that are really above and beyond the benefit. So I think what really makes a hospice different and makes them stand out is the people that actually provide that care, and then the philosophy of the hospice and how they give that care and support the people that are in the hospice as well.
Yeah, the regulations are the same for all hospices, no matter how big or how small they are. And I think that's how you, as you said, differentiate yourself. And I really don't feel that there's a great competition between hospices. It is raising awareness that hospice exists. Agreed. And then having the philosophy of the hospice that you're working with. And there's a number of them in Houston and the United States that work similarly but differently.
Exactly.
And corporate structure does have different layers in it, and they can function efficiently. I work with corporate hospices, but I prefer the local one. I guess it's just more of a personal feel, and then getting to be able to talk to the owners,
right,
and to the staff, and there's not a big turnover in our level of leadership.
Yes,
and so that's reassuring. So it started off really in Katy.
Right? So we started off in Katy. There, I mean, in this small one room. I don't know if I'm sure you probably remember. We had remodeled like 5 or 6 times because we kept growing. But in the beginning, we had people that were sitting across from each other on desks, and I mean, like my office was like this little cubicle that we couldn't. I mean, you couldn't really even meet in. We had to go out into the conference room to meet. And as we've grown, I mean, with this handful of people, there were probably in the very beginning, I think there were like 7. We had 7 core employees. And we've grown to right now, I think we have 113 employees. I mean, over the last, 13 years, we've added a lot of people. We started off with 1 medical director, 1 team. And now we have, 7 teams or 8 teams with associate medical directors that report to Dr. Trumbull. And then, so we stayed in Katy. We moved down the hall because we got a bigger space. Still the same suite number, but we moved down the hall and remodeled a different space. And then we moved about 2 years ago in June to really the heart of Houston. I mean, so now we're really in the Galleria area. We have a beautiful view on the 16th floor of the KHOU building. And it's just an amazing journey, I think, to think that we started off with one patient 13 years ago.
Yeah. And you're right. We were sort of Katy based at the beginning, but serving all of Houston since the beginning. So we were based there. That's where the offices were. And then we'd even have, and to move here, it didn't really change so much the care.
No, not at all.
Location's not important. It is for the staff and for the ability to provide care. Yeah, to be more centralized. And a lot of our teams now are virtual, partly because of the COVID epidemic.
Yeah.
But even before that, I think we were doing some of the teams by phone in.
By phone in. Yep.
So we were already there.
Yes, very, very proactive in our forward thinking. One of the other things I think that is interesting and different about Vantage, a differentiator, I mean, again, not as a competition thing, but just as a who we are thing. Everything that we do is under one roof. So we only have one office. So if anybody were to call, any patients or referral sources or anybody calls, they get the same group of people all the time. And if somebody needs something, or if there's a question, or if a caller, especially, families, if they're in crisis on the phone, there's a group of nurses that are literally sitting behind our office staff. So they just go grab one, which is really interesting. We don't have a north and a south or an east and a west. It's all just one group of people. We're all under the same roof, which, I guess could be contributed to my sense of control or whatever you want to call it. But I just think it's easier. It's easier to manage people when you can see them, and it builds rapport, and there's a higher level of accountability when the administrator is down the hall, literally. I can get up and talk to people, and I'm involved, or I overhear conversations and can intervene real time versus maybe waiting for a meeting, a week later to hear about an issue or a problem. So I think that is something that stands out as a differentiator. And I think that really is one of the reasons that we are so successful, because the process is the process is the process. And there's only one. There's only one process. And we monitor that process all the time. So.
But the teams are coordinated as north, south, east, west, for different areas, even though we have the one office, as you say. So that,
right.
I think that is advantageous. And we've thought about whether to have satellite offices.
We have.
But what would be the benefit, and would it be better for the staff, or the team, or the patients? And I guess we've always come up with
no.
We can do it under one roof.
Yeah, we've always agreed that. The core structure of who Vantage is under one roof. Again, like you said, teams are in geographical regions across Houston. Nurses live where they provide care. Aides live where they provide care. The social workers, the chaplains are all in that area, and that, builds that sense of community, so that they're available quickly, in the event that a patient needs something, or a family needs something, or a referral source needs something.
Mm-hmm.
But then just the overall business aspect of Vantage and decision-making things are all here.
Yeah. Okay. There's, the concept of hospice and palliative care is sometimes confusing to people. What's the difference between it? Well, both hospice and palliative care provide a symptom-centered care. And the main difference really is a hospice patient has a terminal illness with a limited lifespan measured in terms of months.
Correct.
Palliative care also addresses symptoms.
Mm-hmm.
That's a center of the care, but it may be longer than months, maybe years. It's not necessarily a terminal illness. And some people are better able to relate to palliative care because they don't feel like maybe dying is an issue that they're not able to address. And so there's some overlap. Sometimes it is a a continuum. And so we decided that we needed to have that in order to communicate better what the goals are for hospice. And so
Right.
Nicole had an interest and expertise and the
Yeah.
drive.
So I've been a nurse since 2000 is when I graduated from nursing school.
Mhm.
And had been a nurse for, quite some time, and realized when we started talking about palliative care and the interest of palliative care and the need of palliative care, we started interviewing nurse practitioners, because I couldn't do it. I'm an RN, right? And then after interviewing a lot of people, again, my sense of control, I think, overwhelmed everybody, myself included.
It's a good sense
It's
of
a
control.
good, yeah, control. So I was like, and I mean, as a joke, at one of our management meetings, I had said, why don't I just go back to school? Because at least we'll know that whoever, I understand hospice, I understand palliative care, I know what I want our program to be. Why don't I go do it? And surprisingly, they said, sure, go ahead. And I'm like, oh, okay. So
You were surprised.
I was
maybe we weren't
completely surprised. In 2019, I went back to school, got my nurse practitioner in 2020. Was it that? I think it was 2020. I think it was 2020. Yeah, it was a hands-on, but actually it was both.
So
It was
9 years into our
9 years into our hospice. I went back to school in the height of, I think it was 2018 actually is when we started, because it took me 2 years to do it.
Okay.
But Dr. Trumbull graciously wrote my recommendation letter for school, which was awesome. But yeah, so we decided to start palliative care. We had a handful of patients that we were providing care to. And then we ended up finding a really awesome nurse practitioner, Sony, who stepped in and really kind of just spearheaded everything and has taken the program from, one patient to, I think 70 is what we usually run right now in the palliative program, and service the entire city of Houston. So, always available to help if anybody has any questions about that, about palliative care. So palliative care is an interesting little caveat. I think it's funny because we were just talking about that in my office before we came in here about just the pocket of what palliative care really is. There are no technical requirements. There's no list of requirements you have to be on palliative care other than have a chronic illness. A lot of people view palliative care as like a stepping stone to hospice. I've heard it referred to as hospice light a lot. Really, it's managing symptoms at home. The goal for palliative care is to keep people out of the hospital, but you can still pursue aggressive treatment, which is different than hospice. So hospice is more comfort focused. We want to make sure the patient is comfortable and symptoms are managed. And you're really at the point where you're not aggressively seeking curative measures for your illness. Whereas palliative, you can still do those things. You can still get radiation, for example. You can still be doing, chemotherapy for cancer treatments. It's probably one of the easiest things to talk about is a cancer patient who maybe has uncontrolled nausea and vomiting. And they can't get it controlled, and it's a big issue, and it's a quality of life issue for the patient. You could refer that patient over, or the patient could call the palliative care program for an uncontrolled symptom, which is, nausea and vomiting. And then we could come in and manage that symptom while you're still aggressively pursuing chemotherapy. So that's one of the cleanest cut, I think, explanations of the difference between palliative and hospice.
Yeah, and there's different payment sources for palliative care they have available to them that hospice doesn't, because when you get into the Medicare Part A, Part B,
Correct.
And so hospice is limited to the Part A. Palliative care is not limited to the hospice Medicare benefit, and so they're still in traditional Medicare or other payment sources.
Correct.
And so that's why there's availability to do different forms of therapy and treatment, which really would be outside of the ability for hospice to pay for.
Correct.
And then, of course, you're right. They don't have a terminal illness. It's more of a chronic care.
Yeah.
Chronic care focus.
Right.
on patients.
Again, I think one of the most important things about palliative care, and one of the things that really drew me to it, is the ability to meet the patient where they're at. Because it really focuses on what are your needs, making sure the patient has the right level of care at the right time. One of the things, being a hospice nurse for, 20 years before started the palliative care program, one of the biggest things that I always heard as a admission nurse way back when is, I wish I had known about hospice sooner. That's one of the things that we always heard. And so being able to talk to patients sooner and not necessarily admit them to a hospice program sooner, but letting them know that hospice is out there and what it truly is. Because as we all know, hospice is a scary word. I mean, people get scared when they hear the word hospice and they think that it means I'm dying tomorrow. They're going to give me some morphine and I'm going to die tomorrow. That is not what hospice is. And I think palliative care really does kind of provide that bridge.
To bridge the gap. Yeah.
Bridge the gap between the unknown and the known, and how we get them from a place of getting the right level of care at the right time, because that really is, across the board, the most important thing I think that families and patients need to focus on is making sure you're where you need to be, when you need to be there, and getting the full benefit of whatever that program may be as soon as possible versus waiting till the last minute. Because building and establishing rapport with a hospice team is important. And not that we don't, hospices come in all the time. I'm like kind of a little off topic here, but hospice companies can come in, at the 11th hour and definitely provide support and care. But it would be much more beneficial to the family, to the patient, and to the team if we were able to establish that rapport with that family sooner versus later, and really have them get the benefit of the support that we offer. So that's kind of what we're using palliative for.
Ideally to
a
do
stepping
that.
stone to help.
And so if they're still undergoing treatment, curative treatments, or at least diagnostic and curative treatments to get to a certain diagnosis, they don't have a terminal illness, but it's possible, especially if the treatment fails. So if they're undergoing chemotherapy and radiation for cancer with the hope of being cured, but they have a lot of symptomatology, that's palliative.
Exactly.
If it gets to the point where it's clear that the treatment has not been successful and they're going to need to transition to a terminal condition beyond hospice, and to have the same providers, or at least the same company, to say, this is the same people that have been helping me out with the palliative care now will help me at this stage, which is something that maybe they didn't want. But the reality is that they're going to be dying. They're going to need symptom management through that. And we can provide both services, palliative and hospice.
Absolutely. I think one of the other things that you just triggered in my brain is just the diagnoses. It's not just cancer. So we're not just, hospice and palliative care is not just focused on cancer.
Right.
That's how it started. And we were very focused. Medicare was very focused on cancer and making sure that cancer patients were very well palliated and had an option, if when their treatments were no longer successful. But that's not all that we do. We manage all kinds of diagnosis,
with heart disease, lung disease. A lot of neurodegenerative diseases.
Absolutely.
There's a whole list of them. Alzheimer's and dementias are a big one. And then chronic lung disease and heart disease, and those, and then kidney disease. Any organ system that reaches the point where it's failing and no longer support life.
Right.
That's where hospice is.
Right. Yeah. Exactly. So, it kind of, just to wrap things up, and in conclusion, I just wanted to say, essentially how grateful we are about kind of where we started and where we've ended up, and just how fulfilling it has been, just physically, not physically, that's not the right word, professionally and personally, how rewarding working in hospice truly is, and being able to help people in real time. When you're a nurse on the floor, you see these people for 1, maybe 2 days, and you never know what happens to them after that. Unless they come back to the hospital. But in hospice, and palliative care, you are with patients at least every week. I mean, you see them every week, you see families, you become part of their, their inner circle and their support system. And you know that you're helping. I mean, there is no doubt. I mean, it is instantaneous, when you do something and you see an outcome, patient is in pain, we give them medication, we stay there till they feel better. It's just an instantaneous, gratifying thing. So I don't.
Yeah, and as I think back about it, as I said earlier, I admired my mother, who was involved in early hospice establishment in Houston, and I wanted to be involved in hospice. And it was amazing to realize that at some point I was able to be a hospice doctor, and then get involved with hospice, and then get that experience. And then I think one of the best decisions I ever made was to say yes to come to be with Vantage Hospice. I turned down other hospices before. I'm glad that I said yes, because it's proved to be very rewarding. The vision that I had and that I shared with others at Vantage has really come to fruition, and probably exceeded what I thought it would be in terms of how large we've become.
I know, agreed.
How many people we've been able to help at this point, at this special point in life where you're dying.
Yep.
And you can help them, the families, and then even the healthcare professionals that are involved with that care. It needs to be satisfying, rewarding in many ways, but primarily to know that you're doing the right thing at the right time in somebody's life, and that may be the end of life.
Thank you for watching our podcast. It's as stated earlier, this is the first of many that we're hoping to complete. So please stay tuned and come back and see us.